So I'm going to whip through this presentation, and then I'm going to leave it to Brendan Crotty to summarise the meeting for us so that we can hopefully depart on time. So I'm just going to go back to an overview and then pick the eyes out of a report that was done by one of our good friends, Stephen Duckett, not so long ago, that actually Renee put in front of me originally and said, put your mind to this and see what you think. But we know that a large percentage of us live in regional centres, rural and remote, and that if we look at avoidable deaths, that there's a large excess of avoidable deaths in regional and rural areas. And we know that there's a bunch of contributing factors to those deaths: educational levels, lower socioeconomic status. There's a lot of behaviour and adverse health behaviour, higher rates of chronic disease. We know that there's poor access to information and literacy we've heard about today. Certainly some barriers to access to health services, and I tossed in the last one, which I think is important, and that's there's a difference in biology in some communities, perhaps less so in Victoria. So we're all, those of us in health services are anxiously awaiting the outcome of the current Duckett review in Victoria, but there was a recent review about that spoke to about the perils of place and identifying hotspots in health inequalities. So there's this notion of, and I'm sure people like Tim are aware of this ambulatory care sensitive conditions. So these, in my simple mind, are basically illnesses that really should be treated outside the hospital setting, but you can measure them as a surrogate measure of how well your health system is performing. And these include things like diabetic complications, dental conditions, and you can see the rest of the list there. And they to some extent speak to prevention. So they might be primary or secondary prevention, and it also speaks to a very functional health system which consumers can easily access and get health care in the appropriate place. So if you have a high level of ACSCs, ambulatory care sensitive conditions in your community, probably means things aren't going too well. So what Duckett and colleagues did was take a look at these conditions and define them as being hot or regions or areas that had an excess number of these that are hot if there was more than 1.5 times the average figure. And this analysis is very relevant to us because it was done both in Queensland and Victoria. And you can see the figures there. So, you know, your area is performing very badly if you're at three times the national average. And what you can see is that this is intimately related to socioeconomic status. And so those regions with low socioeconomic status have a larger number of hotspots in those areas. So a larger number of people being admitted to hospital for conditions that really should be managed out of hospital. True both in Victoria and in Queensland. And not surprisingly to this audience, that coincides with regional areas. So if you are in a non-metro area, it's much more likely that you'll have your region will be represented by hotspots in conditions that are, should be managed outside hospitals but are being admitted to hospital. That associates with a disadvantage, of course, and no one's surprised to hear that there's more disadvantage in rural and remote communities than there are in metro. And there's also confounders, including the level of remoteness and the proportion of Indigenous people within a community, more strikingly in Queensland than in Victoria, but nevertheless important in our community as well. So I was thinking about that and some of the work we've done. I don't know if Margaret Henry's still here, but Margaret, who gave us a nice presentation on diabetes and oral health, was working with us and in the cancer space, and came to me one day and said, "Oh, I've done an analysis and I think people who present through the emergency department with cancer die." And I said, "Oh, that's interesting." And serendipitously at the same time, Sveta Venkatesh, who we were doing some big data work with, came to the same conclusion. The strongest predictor of an adverse outcome in cancer at Barwon Health was whether your presentation with that cancer is through the emergency department. And if you had multiple admissions to the emergency department before that diagnosis of cancer was made. So if you think about this, we really shouldn't be diagnosing cancer through an emergency department. Sometimes it happens, but what to me, we started to look at some of this, and when Margaret, this is not in the paper, but when Margaret started to look at it, it coincides, not surprisingly, with socioeconomic status and remoteness. People with low socioeconomic status, remoteness, present with advanced disease, present through the emergency department, and often the diagnosis of cancer is missed in the emergency department for whatever reason. They have multiple presentations and their mortality rate is very, very high, even when you control for different types of cancer. So the distribution of access to care, the patterns of care, and the way we're caring for people in our communities has real impact on whether they're going to be dead or alive, and these are sort of the reasons. So there is a big health divide, and this is the slide that I showed at the start, and these are the contributing factors to that. So I think this group has done a marvellous job, in my view, and I'm very proud of the progress we've made in the Western Alliance. It's starting to address some of these important factors. But it's not just those biological factors, when policy does affect outcome, and I think it's up to us to start to talk to our politicians and our legislators with data around this, and this is just one example. The proposition that was made to start to charge a larger gap and the impact that in Medicare, and we all have different political persuasions, but the impact of that will certainly be later presentations, less direct care from primary care providers, and more admissions to hospital. Linking up people, systems and data, we work in silos. I think it's incredibly important, and we've heard a lot about that today, and I'm sure Brendan will speak to it, about silos of information and the way we can approach it. So what are we doing to help? We're engaging with our health service partners, we're creating collaborations, we're funding startup research, we hope that we're creating a network of mentoring for novice researchers, training, network brokerage, and we're going to speak about the website in a moment. So our strategic direction, one of the major strategic directions is engagement, and you're all here and we're hoping we're engaging, particularly with our partner organisations, at the staff level with communities, and we've heard a lot about that today, and we've got more communicating and engagement to do with our policymakers and particularly with industry as we grow over the next decade, hopefully. We think, and without being a spoiler alert, that this is going to be really important. Data, and we're working away at this in the background, and I think we'll have more to say about that over the next 12 months, hopefully. What are our achievements? We think the Western Alliance and the Western Alliance community has done a fantastic job with the little resources that we do have to spread around, and I'll just take you through a little bit of that. So Steve Allender's group, they're our shining light. In 2014, when we started, we funded 3 highly visible projects. Steve Allender and Colin Bell's project in childhood obesity has already translated into 1 published publication. There's 7 in preparation. There's been 21 abstract meetings presented, and then a series of grants. The biggest one you can see there is a nearly $4 million grant, of which at NHMRC, of which the Western Alliance is a cash partner. So we think that we've levered and influenced that, and that's a great success. The other two projects funded in that year, John Tombaru's project, again, a number of presentations and reports, and we await the formal report on that, which is not quite due, and Julie's group has done a great job in translating the third funded project, and you saw a lot of this today, which is a growing data set that's really important and will help us shape the future of our community. 2015, we had 71 research ideas proposed and submitted. 11 full proposals were reviewed and 3 were ultimately funded, and we await those and their outcomes. So this includes cancer strategy, farm-related major trauma, and a 20-minute rounding survey, of which the poster was presented today, and I hope everyone had a chance to look at that. We're in the process of reviewing our 29 research ideas from this year, and we've got 8, and we heard about 4 of them today, and they'll be some of those will be supported financially, and that's been another great success. And additional research, including a Hearts First study, and another study funded by the DHHS called What Matters Most. This is a study about patients' wishes in the hospital, and having medical staff listen and document patient wishes more accurately. Workforce capacity building, hats off to Renee and the team for rolling this out. We've had a lot of lunch and learns, introduction to research days. We've been able to help 2 hospitals establish research and quality committees. We've had brown bag sessions, on-site drop-ins, video and other resources, and we're going to now, I think, speak about raising the profile in general, our annual symposia, scientific meetings, formal submissions to the Victorian Department of Health around the research strategy, which has now been published. We did get a mention in that, which was good. And we were invited to the Federal Parliamentary Standing Committee, and we've been helping our partner organisations with advice on planning for research strategy. Things take time, and this is a work in progress and continuous building.